Good morning, everyone. Myself, Dr. Vandana Senan, PG Resident, Department of Medicine, Guru Gobind Singh Medical College and Hospital, Faridkot. In MAPICON 2020, I'm going to give an oral presentation, Sjogren syndrome as polymyositis in a diabetic patient. An interesting case report. An insight into the case, a 60-year-old female presented with complaints of pain in both lower limbs, more in the thighs and progressive weakness in all the forelimbs since 1.5 months. There was history of difficulty in combing the hair. There was no history of fever and no history of trauma. She was a known diabetic since the last 9 years with an uncontrolled diabetic status. Consumes mixed diet and there was no other significant past or personal history. Provisional diagnosis of diabetic amyotrophy was kept, but further workup of the patient revealed an interesting scenario. On examination, patient was conscious, oriented, GCS was 15, higher mental functions were normal, cranial nerve examination was normal, motor system power was 3/5 in all four limbs, deep tendon reflexes were lost. Sensory system examination showed loss of pain, touch and temperature in the lower 1/3 of the leg and the foot. Bowel and bladder functions were normal. Workup of the patient revealed normal total and differential leukocyte count. A hemoglobin was slightly on the lower side, 9.3 gram percentage, with a microcytic hypochromic picture. Platelet count was within normal. HbA1c was 10.8 percentage. Serum electrolytes revealed a low potassium level of 2.8 milliequivalents per liter, along with lowered serum magnesium levels of 1.12 milligram percentage. LFTs and RFTs were within normal limits. ESR was raised 130 millimeters per hour. Serum vitamin B12 levels were within normal limits. Total CPK was raised 4,860 unit per deciliter. EBG showed a combined metabolic and respiratory acidosis picture. Antibody profile revealed positivity for anti-SS-A and anti-SS-B antibodies. Otherwise, the ANA profile was normal. Schirmer test was positive, which was suggestive of keratoconjunctivitis sicca. So from this, we got a diagnosis of Sjogren syndrome. So the next step was proceeding to the nerve conduction study. Nerve conduction study, the final interpretation of the study was decreased CMAP amplitude in the right tibial, prolonged CMAP latency in the left median nerve, absent F waves in the right peroneal nerve, and absent sensory nerve action potential in right sural, with decreased SNAP amplitudes in left sural and left median with prolonged SNAP latency in the left median. So the NCS suggests a sensory predominant axonal neuropathy. Following the nerve conduction study, in view of the raised CPK levels, a muscle biopsy was done on the patient, which revealed a picture of polymyositis. So from the workup of the patient, a final diagnosis was made, which is as follows: diabetes mellitus with Sjogren syndrome with muscle and nerve involvement. And the nerve involvement was a sensory predominant, that is sensory more than motor type of axonal neuropathy with the polymyositis. And this patient was treated with injection cyclophosphamide, pulse therapy followed by maintenance with the azathioprine and prednisolone. Now going to a discussion regarding this case. In this patient, the probable causes of neuropathy, one is diabetes. Diabetes mellitus is in fact the most common cause of peripheral neuropathy in developed countries, especially if the patient is having a long-standing, poorly controlled diabetes mellitus. And the most common form of diabetic neuropathy is a distal symmetrical sensory and sensory motor polyneuropathy. Other types include autonomic neuropathy, autonomic diabetic amyotrophy, and diabetic mononeuropathy. The second possible explanation for neuropathy in this patient is Sjogren's associated neuropathy. So a quick snap of the Sjogren's. Sjogren syndrome is a slowly progressive inflammatory autoimmune disease which is affecting the exocrine glands. But it will also have extraglandular manifestations which are affecting the various parts of the body. One among them is polyneuropathy, and in Sjogren's, sensory and sensory motor neuropathy is common, and it occurs as an immune complex mediated process. Next, regarding the musculoskeletal involvement in Sjogren's, it is having a very diverse clinicopathological spectrum. Among 33% of the patients with primary Sjogren's, myalgias and muscle weakness has been noted. Even subclinical myositis, that is myositis which is revealed only by histopathological examination, is also a frequent association that we can see. But true myositis is found to be very rare. And in fact, polymyositis is even more rarely associated with primary Sjogren's syndrome. And if we are getting an inflammatory myopathy in Sjogren's, it is indicating that there is an immune reaction which is happening in the muscles also, in addition to the other autoimmune manifestations of the disease. Now, how is diabetes and Sjogren's related? With type 1 diabetes, Sjogren's can be an association, whereas in type 2 diabetes mellitus, the incidence of Sjogren's was about 4.1% in 2 previous studies which was done. Actually, type 2 diabetes has been found to express autoimmune characteristics, including the presence of autoantibodies against pancreatic beta cells and self-reactive T cells. The two main autoimmune associations with the type 2 diabetes mellitus, one is psoriasis and the other one is rheumatoid arthritis. With the Sjogren's, studies are just recently coming up regarding the association of type 2 diabetes. And this is also presumably considered to be an immune-mediated process, but we need further studies for delineating the actual pathogenesis. So coming to the conclusion, this case brings out an association between diabetes mellitus and Sjogren's. Neuropathy in this case can be explained by either diabetes or Sjogren's, and the explanation for polymyositis can be attributed to Sjogren's as an immune-mediated extraglandular manifestation. Thus concluding that polymyositis with Sjogren's should be sought for even in a patient presenting with the sensory neuropathy predominant features, owing to its more common subclinical nature of presentation. So this is all regarding this oral presentation. Thank you.